A very good evening to one and all. On behalf of Vincas and our core members, Dr. Josna Madhuri, retired professor at Health Department of Cardiology in NIMS Hyderabad, Dr. Sarita Rao, senior interventional cardiologist, director cath lab at Apollo Hospital Indore, Dr. Sujata V. Pala, director cath lab interventional cardiologist at Indus Hospital Visakhapatnam, and Dr. Shiba Takkar Chabra, professor, Department of Cardiology at Dayanand Medical College and Hospital, Ludhiana. I welcome you all to today's meeting. Today's meeting is specially curated on a very interesting topic, that is dyslipidemia in women, where we will dive into the different aspects and the different dilemmas related to the lipid disorders in the women, how women they are different from the men. And to start the meeting, invite and welcome our worthy chairpersons, Dr. B. Somaraju, an eminent cardiologist and mentor, director at Sindhu Hospital, Hyderabad, Dr. Sarita Rao, Dr. Sujata Vipala, to join as a chairperson. And joining with them is our distinguished panel of experts. I welcome Dr. Amrish, Dr. Abraham Sir, Dr. Asha Mahilmaran, Dr. D. Prabhakar, Dr. Geeta Subramaniam, Dr. George Koshi, Dr. Heathan, Dr. K. Gopalakrishnan, Dr. Mazela, Dr. Priya Palinkar, Dr. Rajgopal, Dr. Rajeshwari Nayak, Dr. Sampath Kumar, Dr. Selva Rani, Dr. Shiba George, Dr. Shiv Prasad, Dr. Tripti Dev, Dr. Veena Nanjappa, Dr. Vijay Lakshmi, Dr. Zakia Khan. A warm welcome to all of you. Now I hand over to Dr. Sujata to take the proceedings ahead. Thank you so much.
Good evening, welcome all. On behalf of Vincars, we are trying to do a consensus document on an important topic, the dyslipidemia in women. I request all to switch on your videos. And as we pose the questions, we go along the alphabetical order. And anybody who wants to raise a point on the question posed or on the discussion issue, please lift your hand so that we can move the proceedings forward. So over to you, Pavni, can you start? So we'll start with Dr. Amrish, and I request all of you to please contribute your valuable opinions to this consensus statement we are trying to do. This is an attempt, a small attempt by us to do this, and hopefully we do it on a larger scale as we go forward. Pavni, can you present the first question for us? So I welcome all of you to this panel again. And I would like to invite Dr. Amrish or Dr. Abraham to give their comments on how we should, what is the prevalence? The next question. Yeah, so basically, no, go back, Pavni, go back. Next. Pavni, don't get tense. Okay, so what is the prevalence and pattern of dyslipidemia, and how is it different in India, and how is it different in urban versus rural? So could I invite some comments on this issue from Dr. Abraham?
Okay, so thank you very much for inviting me. So there are a few things in the sense like, or most of our data we know comes from the ICMR study. And what was clear for both men and women, the commonest abnormality was low HDL cholesterol. But I would like to hear from Dr. Prabhakar also, because he's very strong part of Lipid Association of India. So the non-HDL cholesterol is to me, following LDL is the most important thing for both men and women. The interesting pattern was the multiple lipid abnormalities were common, and the difference in urban and the rural, it's very interesting. Urban women had more high total cholesterol, and higher LDL cholesterol, whereas rural women had higher or the triglycerides were higher and low HDL cholesterol incidence were also higher. Though there is some of these studies, including the Karnataka study in women more than 45 years, and they showed that the women have multiple lipid abnormalities when you take these 4 or 5. But interestingly, lipoprotein little a does not figure in any of these, which is an important thing, which, like, if you have a consensus, I think that has to be mentioned and that has to be done. So in short, lipid abnormalities in women are around 70%, and predominant it is low HDL. And in urban people, our urban women, it is high cholesterol, high total cholesterol and high LDL cholesterol. Thank you.
Dr. Prabhakar, Dr. Somraju.
Can I go? My voice is poor, please bear with it. Suddenly my voice is gone a little bad from today evening. What woman said, I totally agree, but couple of points about that. The HDL is low among women, the percentage is more. Basically because the cutoff point for women is higher. It's more than 50. That is the primary reason why they have a very high amount of low HDL. The other point is the triglycerides are also higher among the men than in the women. So women have a slightly low level of triglycerides. Having said that, I don't know whether I could talk now about it. The high triglycerides are more of a risk factor for women than men. That's a slight difference that is there. And the importance of HDL cholesterol today, we are not very sure. Prevalence, I think he has given clearly, Dr. Uman has said clearly what the prevalence is. It's pretty much there. And if you look at the urban-rural differences also, I think it's all from the ICMR Indiam. That's what we are talking about.
Yeah.
And I think there is nothing new beyond that because that's true pan-India data that we have.
Sir, do you have any data? Do we have any data in India about the lipoprotein A? Any of the participants in women versus men, do we have anything?
I don't think there is anything specific about LPA, but overall LPA prevalence has been mentioned. 15 to 25% has been spoken of in India. I can try to get you a reference if you want on that. I don't know whether there is anything specific about LPA. There have been studies in secondary prevention, but in primary prevention, there is not much of a data. The other point the woman was talking about is the non-HDL cholesterol. It's also touted as the poor man's apolipoprotein B, where you can actually, is going to be a good screening point, which is what most of the guidelines say. And the Lipid Association of India also says, for screening, you don't need fasting, just go ahead with the total cholesterol minus HDL. I think we can also stick to that.
Prabhakar, one point is that we have nearly now 2,500 patients in primary prevention population, but we have not analyzed the male, female, etc. But we have data, which could be interesting because there is at least 30% were women, and that is a good number. So 30% of 2,500 will be nearly 7,700, 800. So that would be when we analyze it, and I would need your help or everybody's help to analyze this data, because that would be interesting, because they are complete data, including HS-TROPI, HSCRP, lipoprotein little a, CT coronary, echo, and the central obesity, which is often forgotten, and waist height ratio, which I think is more important than BMI. Thank you.
Can you pose the next question, sir?
Having said that, I want to ask you a question.
Thank you. I agree with both the speakers. They highlighted everything. The interesting aspect is HDL being low is almost more than 75% of women. That's very unusual for any other population. Thank you.
Yeah, all the studies are showing that, sir. Almost 78%. One of the studies has shown. And sir, Somraju sir, how do we screen women? Like, what are the factors? Like in India, we are not looking at the other factors apart from the traditional risk factors. Isn't it time that we measure the non-traditional factors, and what do you think?
Whatever is available, we should consider only as a preliminary data, and we need to do a lot of work more. But the existing information, I think, is enough for us to try to act on it. Thank you.
So Asha,
Yes.
so what are the factors that we should, the non-traditional factors you think we are neglecting and should look
I
for
think,
in women?
if you look at any cardiology history or case taking, even today, it does not include the adverse pregnancy outcomes, history of GDM, history of PIH in women, history of PCOS, early menopause. None of this is recorded in any of the cardiology case sheets, even in corporate or medical colleges. So first of all, we need to start introducing this into the pattern. Only then we can collect data as well. And as a WinCars group, I think we must be committed to collecting our own data. If we are almost 300 women cardiologists, and between us, we can definitely get more data in women. Like we can have LPA, 1,000 women premenopausal versus postmenopausal, and we can see what it is. So we need to start generating data, and then we can be more confident in coming out with our guidelines.
So I wanted to ask you the most important question, partly the next question. When do we screen? Like we know that in Indians, we present a decade earlier. When should you start screening? There was an interesting discussion in the last meeting. Should we screen immediately after Menarche? Dr. George Koshi, Dr. Geeta Subramaniam. When should we start screening women?
No, I think it depends upon the clinical profile of the patient. For example, if the patient has a strong family history, or you are suspecting familial hypercholesterolemia, heterozygous, or something like that, the screening should happen at a very young age. I feel it should be something like 15 years or something in such people, or even earlier, when you think the risk is very high. But for people with less risk or not having any major risk factor, it may be reasonable to test it by, say, 20 years or something like that. I don't think it can be based on any trial data or anything. I think it has to be based on a consensus.
Do you think because nowadays they say the best time to screen all women before pregnancy should have one lipid profile? So most 80% of the women do not have a lipid profile before pregnancy. So do you think we should start immediately after Menarche? Should we modify because it's the lifetime risk which is more important? Or you think 20 years as recommended in the Western guidelines?
I think the lifetime risk is more important. The earlier you control the LDL, better will be the outcome. And we have enough and more data telling that it is a cumulative LDL risk. The LDL multiplied by the number of years it remained elevated. So we can link it with some event in life, like when the lady gets into college or something like that. It can be linked to something like that, like +2 or before the entry into the college or something like that. So it will be something like the mid-teen. Certainly, it should be before the age of 20 years. That's what I feel. Because if you link it with marriage, the problem is immediately, the statins you may have to avoid before the patient considers pregnancy. 3 months will be a reasonable time. So if you link it with marriage, it will create a lot of confusion because, someone diagnosed dyslipidemia, disclosing that and all that.
Dr.
I think
wants to say.
I just want to have one point. I think if we keep it very catchy, then people will remember it. We'll keep it at Sweet 16 for screening. People will remember it. And it will be just post-Menarche. It will be just post-Menarche.
No, I have a point on this. So you
Okay.
want to fix a time which I did. That was my recommendation in the LAI guideline. So when you finish college, when you finish school and enter college, there's a right time to insist on a screen. A lot of
Yeah.
people get screened. So if you're going to enter college and do a lipid profile, at least a non-fasting, total and HDL cholesterol, you get some information. Similarly, you check your blood pressure also. It gives you a lifetime opportunity to know where you stand and look for future what has to be done. So I think we can also stick to the same. If you are going to give a recommendation saying it's menarche or sweet 16, no offense, Mintasha, we need to have a justification. And adult women do not change their lipid profile through life. It's only the LP(a) that changes. During pregnancy, also LP(a) increases nearly sometimes twice. And post-menopausal, we all know that the LP(a) again rises. In men, it does not change throughout life. It's the same.
Dr. Prabhakar, you suggest that we do both a lipid profile as well blood pressure. Do you recommend an LPA also at that point of time?
You can do one. LPA recommendation is once in a lifetime.
Mm.
And women with a borderline elevation, 30 milligrams is supposed to be normal. But milligram is not the right way to do it. But all the labs in India do milligram. If you have a borderline elevation where 50 is the higher value, if you are more than 50, it's severe LPA elevation. If you are between 30 and 50 post-menopausal, we ask them to do again because it goes up nearly 20% after menopause.
So that's a good recommendation, I think. I think that will cover that as Dr. Prabhakar is telling. Yeah, Zakia, please go on.
Sujata, may I?
Yeah, Zakia, go on.
So, Sujata, American College of Cardiology recommends that at the age of 18 years, everybody's blood pressure should be checked. So I think 18 years is the right age to not only check blood pressure, but also your lipid profile. So I think 18 years should be the cutoff as per the guidelines that are international for blood pressure as well as lipid.
Yeah, Dr. Prabhakar just said entry to college. I think most of it is
Around 18. Around 18.
Would be around that point of time. So that will cover all PCOS because PCOS patients also. Dr. Majula, you wanted
Yes,
to
ma'am.
say?
Yes,
I
ma'am.
want
If
to
there
add.
is a familial hypercholesterolemia, if the cascade is there in the family, I think a screening for such patients should be earlier, ma'am, by 10 years.
Yeah,
But others, as recommended by everyone around this teenage of 18 or 19 or whatever it is, it's fine. But for familial dyslipidemia, I think the screening should be earlier, ma'am, definitely.
Yeah, I agree with, sorry, I'm interrupting, but I agree with Manjula. According to the American Heart Association guidelines, for a familial hypercholesterolemia, it should be at the age of 9 to 11 years, the first screening. If there is a family strong history, then one screening should be at the earlier, not to wait till 18 years.
So Hetan, I'll continue with you.
Yeah.
What do you think,
The genomic
Pavni, the
testing
next
should be a
question?
dry spot.
So should the screening things change between premenopausal? I think it is covered. Perimenopausal, postmenopausal.
I think all postmenopausal women should mandatory for lipids. Perimenopausal and premenopausal according to the clinical background, but the postmenopausal as the estrogen depletion, then the lipids are need to be monitored in all cases.
Can we go to the next slide, Pavni?
Yeah.
Can I add a point here, please?
Yes, please.
Now, what happens is perimenopausal increase starts 1 year prior to menopause and persists for 1 year after menopause. The LDL cholesterol keeps going up. So does the total cholesterol. But this can be negated. HDL also goes down. HDL cholesterol comes down. This can be negated by leisure time physical activity. It's a documented fact. There is a study to that effect. I think it has to be quoted in your guideline.
Pavni, post the next slide, not this. We'll come back to it. Okay, sir, Dr. Gopal Krishna, sir, how should risk stratification for atherosclerotic cardiovascular disease be adapted for Indian women? Given that we have an early onset and we want to look at the lifetime risk, and how would you risk stratify these women with their risk factors, with your calcium scoring? What would you do? Dr. Gopal Krishna.
Thank you, Sujata. That I don't have the experience of Prabhakar or others, but in my opinion, it should be go with saying the traditional risk factors, non-traditional risk factors, and clinically evaluate a high-risk patient, categorize a high-risk patient according to the either Lipid Association of India or American Heart Association, and then probably it is similar to men. We should not discriminate women because of the sex only. I think we have to take both the risk factors, then family history, including the family history, and move forward from there.
Sir, also apart from the traditional risk factors, we also concentrated on the non-traditional risk factors, adverse pregnancy outcomes in women. I would also like to add your, how would calcium scoring in women add to these risk factors? Is the power of zero strong in women?
Yeah, I don't think so. It depends on the age. Say if the risk factors are very high, a patient has high risk factors. Even in a 40-year-old, even a zero calcium doesn't rule out anything. The calcium score is more is zero above the age of 60. Then it have a more positive predictive value than a calcium score of zero at an young age, because soft flocks can happen. And the screening tool, calcium score is not the right way to do a screening tool unless we do a clinical evaluation prior to going for a calcium scoring.
Dr. Prabhakar, you wanted to say something?
And Dr. Gopalakrishna beautifully highlighted the point. Now, recently there has been a paper which has said that even with a calcium score of 0 in younger people, when the LDL cholesterol is high, there is going to be an increased ASCVD event. So you are going to have a problem. So calcium score should be done in the right way. Older people, power of 0 works. Younger people, calcium does not work. We should highlight that calcium is a marker for atherosclerosis. And that for younger people, it is not a very good thing. There are going to be a lot of people who are going to say calcium score is 0. You're not going to benefit from statins. It is wrong. Even at the lower value, like Dr. Gopalakrishna beautifully pointed out, you're still going to have an unstable plaque, and then you'll end up with an event where that mechanism is different. So I don't think the power of 0 should be applicable here. I think you have to choose the right person and do the calcium score.
And also above 40 years, women undergo mammogram commonly, and it has been shown that breast arterial calcification is a surrogate for equal like calcium score. So we can make a recommendation that all the mammogram reports should also carry the breast arterial calcification data.
Asha, yeah, I understand this point. I was talking with my radiology friend, but she said she was not very impressed with that. I think we should try, this would be a good point for us all to work together and look at the breast arterial calcification in all women undergoing mammograms at least. And
Sujata, can I have a comment here, please?
yeah, Dr. Abraham, please go ahead.
Calcium score, the power of 0 does not happen in people who have familial hypercholesterolemia, smokers, diabetics, and maybe South Asians. We have actually published our own data, same thing, primary prevention group, where about 15-20% of the patients with 0 calcium score, it's a fairly big number, around 700 number, did not had plaques between 30 to 50%. And we all know that they are the ones which create heart attacks. So calcium scoring, routine calcium scoring, I would not be in women, especially, I would not, and younger people, I would not be very amenable with. Another important point is you can make us, it's not even the mammogram, but the CT, any CT chest at any age more than 18 should contain a report about coronary calcium also. That can be done very easily, and tons of CT chests are being done. And so that is where it is, and you can pick up calcium. And if that is there, that also will give an idea. So I think rather than mammogram, most people do ultrasound there. But when you do a CT for any other reason of the chest, please screen for calcium score. That should be our recommendation, because that way we can pick up and have good preventive modalities for a huge number of people.
Yeah, I wanted to you all to highlight this issue because we now have a lot of young women with an MI, and also these young women have a very high mortality. So that's the reason why I want to bring out this point that it is the cumulative other risk factors and the not traditional and non-traditional risk factors which we should be looking into. And now coming to the question of the differences. Yes, sir.
That's Sujata Somraj is speaking.
Yes, sir. Somraj is
Just on most
Ma'am,
of
one
things are
second.
already highlighted.
Can I have a word?
I just wanted to just mention the IT professionals. You have to look at them as a high-risk group. We call it as the IT syndrome. Their
Yes.
lifestyles, physical activity, lack of it, and all other issues considered. Consider them as a high-risk group. And also, if the husband is smoking, that is another issue. Just keep it in mind. Thank you.
Yes, sir. Yes, sir.
Tripti here. Just a few words.
Yes, Tripti.
Yeah, because I see also a lot of IT, like Dr. Somraju told, and young women come with a ASCVD type of, atypical chest pain, all those things, which we have to rule out as we know microvascular angina, all those, which we do clinically. But mostly I have done carotid Doppler, which is easily available. Every radiologist is doing with the radiological work. And when I expect carotid Doppler to be done, immediately they perform it. And even the IMT, the plaques may develop later, but the intima media thickness ratio itself shows that they are atherosclerotic and atherogenic. And from there, we have to risk profile and start primary prevention for them. And this has become a regular routine practice. And I have been following these women, and they are giving very good results by preventing them from getting into, and they understand it very easily. That's a very easy.
Else has experience with carotid intima media thickness.
Yeah, there are even Dr. Ramya also done her thesis in the PhD in the DM also, and there are relationships with the carotid intima media thickness with LPA, with high lipid score and all those things, atherogenic index, everything. And sometimes I have to give them even inclisiran or PCSK9, depends upon the family history and LPA. So then we extend our investigation beyond that. So that becomes the clinical scrutiny, which is easily available as the open label, this thing, atherogenesis. So
is
that
there a difference, Dr. Tripti, in women versus men in carotid intima media thickness?
Yeah, that part I have to look into it. You are right. I agree with you. But I mostly target, because I have a lot of women IT patients coming. So I mostly target them. Of course, men are there, but I am more concerned about women, and they come to me because I'm a woman cardiologist in my field. So that is why I have to look into it. And it is my personal experience, as well as I spoke to Ramya also. I'll talk to her. She had a thesis done. Let me scrutinize that part also. Thank you for your suggestion.
Madam, I want to add something. Can I add something?
Yes, sir. Dr. Prabhakar, sir.
What
please.
happens is when you add intimomedial thickness to the conventional risk factors and all the other factors, how much is the net reclassification index? It's very poor.
Okay, sir.
You do the conventional risk stratification and control all the risk factors. The only point that helps is actually the coronary artery calcium score. The carotid intimomedial thickness has not been shown to be very, very useful in net reclassification index.
Okay. So now coming to the previous question, go to the previous slide, Pavni. Yeah. So now the question of how do we, no, next slide, Pavni. Okay. How should the how should the pharmacologic management differ? Drugs, doses, what are the side effects? So may I ask Dr. Majella, Dr. Priya to comment on this? Dr. Majella, how do you treat women? Do you want to treat them differently?
Yes. Ma'am, regarding the treatment, only in the pregnancy age group, we need to be extra careful, ma'am, because we are unable to use many drugs during the pregnancy period. So in such patients of the childbearing age group, I'll be little more cautious. If there is a familial dyslipidemia, the atherosclerotic there is a high risk and the LDL levels are very high, then nowadays it has been, we can include pravastatin into the, it has been recommended that pravastatin can be used, or even other statins if in familial dyslipidemia we can go ahead and use in pregnancy and in the childbearing age group if recommended. But in the non-pregnant women, my choice of statins, that depends on the LDL variability and the amount of other triglycerides and other things, madam. That depends. It has to be individualized depending upon the individual profile, and I don't feel there's much difference between the males and females. It has to be individualized depending upon each individual lipid profile, and especially rather than the lipid profile alone, the LDL variability also has got a great significance. We need to monitor it frequently. With the same dose of drug, the same patient may have an LDL variability, which is another important risk factor for atherosclerosis. And when coming to the CT calcium score, I also feel that in the less than 40 years, the CT calcium score does not play a major role because it does not pick up this vulnerable plaques, which is going to be the main precursor of a cardiac event in the younger individuals. Maybe in elders, we can use it. And in this less than 40 years of age group, we always putting them before CT, always a Preca test. Sometimes we may miss because we are doing routinely for these young females. We are taking up, they are now coming, young females coming with acute MI. We do not know whether, but always a routine, a simple Preca test is very essential because of the medical legal problems. Also, we have to keep in mind that while subjecting a young female for CT calcium score less than 40, we have to keep this in mind. And if it's absolutely essential, then it's fine. Otherwise, less than 40 years, I'm not for it. We have to identify some apart from an invasive, a non-invasive tool, which is going to predict a vulnerable plaque. Both the CT coronary angiogram.
Okay. Considering, can you hear me? Dr. Majella, we lost you. So, okay. Avni, can you tell Dr. Majella, can you call Majella? Are there any differences between men and women?
Once again, that is got a lot of limitations. We do not know at the most. I think that would be my take on this.
So if we make different recommendations without
but
backup
otherwise,
data, what we will do is we will be under treating women. What will be the common suggestion is give lesser dose of statin. So we may end up under treating women.
So
I don't think we
mean to say we treat similarly. Women, women, you know, are underrepresented in all trials. Most trials carry only 20 to 30% women. So can we apply what we learned from the trials, which are basically made on men, and we can we apply them to women? And Dr. Prabhakar, you wanted to say something?
2 points in this. Pharmacological management protocols different. No, I think it's pretty much the same. But for Indians, we must definitely highlight on all the perimenopausal things that Asha was talking about. All the, not the perimenopausal, sorry, the pregnancy-related risk factors. They call it the common soil hypothesis. There's one more interesting fact. If a female develops a myocardial infarction less than 35 years of age, she actually develops an early menopause. And early menopause is a risk factor for a subsequent cardiac event. So it all is a continuum. So you must expect the same thing in all these people. The second thing about this one specifically is that there is no difference in the statin response to men and women, except the fact that HDL cholesterol goes up higher with women when you give a statin. LDL, there is conflicting reports. Some meta-analysts have said it goes up more. Some say men respond more. Some say women respond more. So you can forget that. The only thing is that women, HDL cholesterol goes up. But apart from that, nothing much is on paper at this point of time.
I have one more question. Considering that women develop more SAMs, statin-associated symptoms, muscle symptoms, do you think the future is going to be combinations like hypertension? Is it going to be combination drugs to achieve the same goals? Should we do that in women?
There are 2 points in this. One is it more common in women? I don't think so. The problem is women, not only women, thin, frail, small built people, older people are more prone for statin-associated muscle side effects. The overall prevalence is about 7 to 9%. That's all. And it has to be highlighted that it has to happen within the first 3 months. Bilateral, symmetrical, proximal, especially lower limbs. That is when it is SAMS, not 2 years afterwards. Orthopedician telling you joint pain is because of that and muscle pain. That is all not SAMS. SAMS has to be defined clearly and treated properly. Second point is combination therapy. I think it's proven beyond doubt. The racing Lodestar have clearly said it really doesn't matter how you bring your LDL cholesterol down. Bring it down. I think it all started off with the Improve It trial, then all the PCSK9 trials. Everything has said bringing the LDL cholesterol down is paramount. No more pleiotropic effects.
Priya, you have any comments on this? Combination therapy, how to bring the LDL down in women? Dr. Shiba George, please kindly your comments on how to get the LDL down.
Ma'am, good evening. Yeah, so. Yeah, is Priya speaking or me speaking?
Ma'am, you go ahead, please.
Okay, nothing much. Statins have clearly shown to be almost equally effective in women as in men. So statins stand as a first-line treatment for dyslipidemia in women, whatever be the level of the lipids. So starting drug first line is definitely statin, and generally women respond to moderate intensity statin therapy. And in lean women, and as Dr. Prabhakar said, lean body weight, maybe we can expect SAMs a little more frequently, but overall the incidence of SAMs is very less. And if the person has SAMs with one type of statin, you can switch over to either you can reduce the dose and then see whether the muscle symptoms improve. If it doesn't improve, we can switch over to another statin. Sometimes if the person has symptoms with atorvastatin, the patient may not have with rosuvastatin. Or pitavastatin is supposed to be effective against SAMs. I mean, SAMs is supposed to be much less in pitavastatin. But I don't know, the availability of pitavastatin is little less, but earlier Pitava 2mg was freely available. Anyway, so changing, no, it is not an indication to stop statin therapy, number one. Number two, we all know that statins should be avoided in pregnancy and lactation. And women who are expecting to be pregnant, we should not be prescribing statin. And for high triglycerides, definitely, despite adequate dose of statin therapy, if triglycerides still remain high, some people respond to lowering of triglyceride with statins, but and lifestyle modification, if triglyceride levels remain high despite dietary modification and better control of diabetes and with the usual statins, then we should prescribe fibrates to them as well. And PCSK9 inhibitors should be prescribed in high-risk patients with LDL goals which are not attained. So these are very clear-cut as similar to men. And generally, we should be cautious about the use of statin in the reproductive age group. Otherwise, women fare very similar, almost very similar to men with statin use, no doubt about it. We have treated n number of patients, women, and they come down with very, if they are adherent to the therapy, definitely the cholesterol levels are very well controlled. Thank you.
Dr. Prabhakar wants to say something.
Okay, hi, long time no see.
Yeah, sir. Nice seeing you, sir. Though the sound is not good.
The point is, US FDA has removed the contraindication label for pregnancy.
Yeah.
They put the onus on the physician or the cardiologist. It has said for high-risk persons you can give, so it is no longer contraindicated. You cannot mention that anymore.
We have Annie Princey here. So Annie, so we have your favorite topic, pregnant women. So how
So
do you?
what do the gynecologists say about it then? Giving statin in pregnancy.
I think
We
it's
have
the
Annie here, so
it is the cardiologist point of view. If the FDA has removed the label and says a high risk person, you can give it, and it is your responsibility. And the and all the avoidance is going to be restricted to people with low risk where we think they're going to benefit. But I think it should be okay.
No,
yeah.
I think, can I add a point?
Sujata,
Can I
Sir,
add a point?
can I
Dr.
ask a question which may sound
one minute, Dr. Suraj,
slightly unusual? Dr. Prabhakar and others can address it. Good evening, Dr. Prabhakar.
Hello, sir.
See, what is the function of cholesterol in the body? Is it like vermiform appendix?
Sir, the point is when you lower cholesterol, everybody says you need cholesterol for synthesis, for the skin, everything. But the point we forget to understand is cholesterol is synthesized inside the brain everywhere. Local synthesis of cholesterol happens. That is how in the Fourier trial, a single digit LDL was safe. Nothing happened. So don't worry, cholesterol has its job.
So,
But there's a sensitive issue about giving it to a pregnant woman. We'll never know whether the child will be born with teratogenic effects, So it's a little sensitive from our side. We cannot have, if the child is born with some defects and all, you will always, it is really a sad thing, not a simple thing. So we don't dare to, though I know that the restriction has been taken off by the FDA. I will never start it on a pregnant female.
Prabhakar, one point.
Can I add a point? I
Go ahead,
think FDA has not really mentioned like that. You can use statin in pregnancy in a situation where the risk is very substantial. That is what the FDA mentioned. Not that you should routinely use statin in pregnancy. That is in a very exceptional situation.
Sir, that is exactly what I said in the beginning. It removed the contraindication, put the onus on the physician or the cardiologist.
Yeah, but I think the judgment is very important. I think one or two situations where probably it can be used. One will be a patient at very high risk, a heterozygous FH with very high LDL. And during pregnancy, the LDL will increase even further. Okay. Or a post-MI patient or someone.
My point was that exactly with same as Dr. Koshi sir. What they said
really
is that the universal contraindication has been removed.
Otherwise, I don't think.
That exactly is the wording. So
I think we should be very, very careful when you give the guideline.
But again, like people with homozygous familial hypercholesterolemia, established ASCVD can continue, but we should be very nuanced and individualized. The onus is on us.
Exactly.
But everybody with some risk factors, ladies, then pregnant women, should we give statins is a question which open discussion, but I would not do. But the wording is universal contraindication of statins in pregnancy is removed.
Because pregnancy is a very short-term affair. It is over in 10 months' time. After that, you have all the time to treat the patient,
Dr. Somraj wanted to say something. Sir, you wanted to say something?
No, I already said that. Again, I have to say cholesterol, some cholesterol is essential and it is not appendix.
Okay, Priya Pamakar, so you don't want to use... Sujata. Yeah, Sarita, I had an inclisiran question ready for you. Tell me, go on.
So, I joined in a little late. So, couple of things. One is that we have to keep the recommendation that women have to be treated as aggressively as men do. Now, where does the problem come out in women? The problem always comes out in women of childbearing age, because that is the time when they are undertreated, right? Because they run the risk of getting pregnant, they run the risk of inadvertent birth defects if they were on a statin, which is why that is the time that most of them are discontinued with the statin. Now, FDA did request that the contraindication against using statin in all pregnant patients should be removed, but they also said that there is still risk of birth defects from inadvertent statin exposure. So that is also there. So the idea is that it has to be given to people who are only at very high risk of ASCVD events or have severe familial hypercholesterolemia, because there is still risk of birth defects. So only very high risk pregnant patient can be continued a statin, and that risk has to be explained to them also. So it's a shared decision making between the physician and the patient. Again, when we are talking about this very high risk patient, because drugs like inclisiran, as you were saying, have to be given once in 6 months, so we have to talk about the fact that giving one shot before these patients become pregnant will probably carry them over beyond the period of organogenesis to 6 months' time. So that becomes an important aspect in this category of patients. Also, the role of nutritional therapy. The very fact that we modify their diet and we keep them on that kind of therapy so that their cholesterol levels are well controlled during pregnancy is also an important thing to look at.
Yeah. So
We cannot make a recommendation that statin has to be given. We have to say individualized decision making based on the risk benefit ratio for the patient.
Would you consider other drugs? Priya? Would you consider other drugs like bempedoic acid, estimate? Can they be used? Inclisiran already Sarita has said.
In
Priya or Hetan, whoever wants to answer.
Ma'am, I have just one. Can I have a word, ma'am? Yes, ma'am. Regarding what Sarita Rao ma'am said, I also totally agree with her that during pregnancy, definitely if it is indicated, if there is a familial dyslipidemia, if there is a risk of MI, if there is the patient is a high risk atherosclerotic cardiovascular disease patient, the score is high, definitely we need to put them on statins because as quoted in Circulation 2022, the statin use in pregnancy is a time for a paradigm shift. They've analyzed almost more than 489 pregnancies and compared with those on pregnancies with statins, with the age match controls, and it has been shown that there is an evidence of definitely low birth weight in these patients and preterm, but still the mothers benefit overweighed all these effects on the fetus. So if it is necessary, we should give them, and definitely pravastatin, though it is not freely available in India, definitely that is a game changer, and it is a more hydrophilic drug that it doesn't have much impact on the fetus, and it has been approved by the FDA and WHO to give it in pregnancy. So definitely this article quotes that if necessary, we have to give the benefit for the mother and go ahead with statins, explaining the risks for the fetus, whatever, and we have to go ahead if necessary. Others, routine patients, we need not give. But for familial dyslipidemia and a high-risk patient, acute MI, we have no other choice rather than to go ahead and explain the risk and treat it.
Annie, since you all are doing a lot of data on pregnancy and heart disease complicating pregnancy, Annie, are you online? If you're online, please let us know your thoughts on this. So I think she's not online. Priya or Hetan? Use of other drugs, use in pregnancy or in women. Because the Clear Outcomes trial is the only trial which had almost 50% women. So other drugs like bempedoic acid and Estimate, women respond similarly. Do you consider giving combinations? Sarita, you want to give combinations?
In pregnancy or in women per se?
In women in general.
In women in general, yes. According to the latest recommendation which has come in, it goes for aggressive LDL lowering. Yes, we would combine, if the goal has not been achieved in 4 weeks, you would need to up-titrate and combine it with first an estimab. If that gets you to your goal, fine. If it doesn't get you to a goal, you shift to a combination of also bempedoic acid. So aggressive lowering today is the key. It has to be done in patients who are at risk and who are not at their goal.
So your acute coronary syndrome patients, women, how are you treating them? Are you treating with combination from the very beginning? Are you differing in the treatment from men in your ACS patient?
We are not doing it differently, but for all patients with acute coronary syndrome, men or women, if they are not at their targets in 4 to 6 weeks, we escalate and we use combination therapy.
Do you think 4 to 6 weeks is late? Sir, Dr. Prabhakar.
Yeah, that's the problem. In fact, the ESC guideline was released this month also says you are justified in an upfront combination therapy. So what we can do, in fact, there is a LIE-REACT study which has said, even if you give a triple combination therapy, Kunal Mahajan's paper has said that if you give a triple combination of 40 Rosuva, ezetimibe and bempedoic acid, only 70% achieve goal LDL. Still you miss 30%. And to wait for 4 to 6 weeks is bad because nearly 10% of the events happen within the first 100 days. And 4 to 6 weeks is quite a long time. You're missing
Sir,
half the
Dr.
time.
Prabhakar, so you would be giving rosuvastatin 40 mg and an estimate combination in all your acute coronary syndrome, whether it is a man or a woman.
I give all three.
Oh, even bempedoic acid. So
Why do you
triple
want to wait?
therapy, all patients, irrespective of their lipid profile, irrespective of man or women, you're giving triple therapy.
Exactly. Why do you want to deny him a lower LDL? Lower the better, lowest is best has been proven.
No. I understand the point of giving a triple combination therapy in a patient who has got very high levels. But most of our Indian population have medium levels of LDL cholesterol. Would you still hit them with all the three agents when they come in?
So Indians, according to the UK Biobank data, have a 10 milligram per deciliter lower level of LDL cholesterol, which is what you're quoting. But their coronary artery disease happens 10 years earlier.
Yes.
The MI happens 10 years earlier. So at a lower level of LDL, we are more prone. That is why we have to bring it down even further. It's important because you don't deny them that benefit in the early phase. That is when plaque stabilization is going to happen.
Zakia, you agree?
Yeah, I mean, after these change of guidelines for ACS, as a practice, I start everybody on a combination of statin, hidostatin, and ezetimibe in an acute phase. And in 2 weeks' time, I repeat their lipid profile. They are not on goal, then I add the third drug. If they are on goal, I go on, continue the combination of ezetimibe and this. So I personally feel it's not recommended to start all three, but you should check first at the end of 2 weeks what is the response.
Dr. Prabhakar is making
add something
guidelines in view of the Indian study by Dr. Kunal Mahajan, where he's quoting that 70%. Should we all change our practice is a question we should answer. That give triple therapy, Indian man or women, triple therapy because we are presenting early. Sir?
The guy who started this first is Abraham movement. You ask him how his response is.
Dr. Abraham?
Think quietly.
Yeah, because I was part of most of these clinical trials, so I started much before and giving triple therapy. My mantra is very simple. If the LDL is more than 110, to reach 50 or 40, we have to give 3 drugs. So, and lower the better. And as Dr. Prabhakar elucidated the reasons behind it, but it's much more easier to achieve early and then maintain. So we are routine as a practice. The day bempedoic acid became available, all ACS patients, I give upfront triple drug combination. Only exception may be very young girl, or we are very sure that's plaque erosion. So in that situation, I may not be very aggressive. Means there, I may give 2 there, but then still, even microvascular disease, we know that there is a significant atherosclerotic part there. It's just not spasm there. So I tend to be aggressive. And side effect profile is absolutely great. And same thing around 70 to 75%. So I shifted from Repatha to triple drug therapy a long back because it is poor man's Repatha as effective with 1/10th or even lesser than the cost.
So
can I add something? Ma'am, can I add something?
Yes, Shiba, ma'am.
Yeah, in my practice, what I do is, as a patient who comes with an acute ACS, we send an extended lipid profile at that time. Okay, that includes a lipoprotein little a also. So if the lipoprotein little a is above 30,
I prefer to give a PCSK9 injection also inside in the ICU or pre-discharge, apart from the high dose rosuvastatin 40 mg plus ezetimibe. So if the in ACS settings, earlier you try to control is better, as Dr. Prabhakar said. So I also try to give a PCSK9 injection within the first 24 hours of the ACS, and follow up with once in 2 weeks injections for at least 3 to 6 months time, if possible, along with the routine monitoring. Thank you.
So, Dr. Prabhakar and Abraham, you're not using PCSK9 at all with the current triple therapy?
Mine have come down dramatically because I got a big grouse against this 3 to 6 months, frankly, with due respects, because there will be a rebound. We have seen patients who have stopped. They won't rebound in 3 months, 6 months. But 1 year, most of the people I had seen were 3 doses, 4 doses of short-acting PCSK9 were given. At 1 year, their LDL were, I got a series more than 100, 120 patients, not mine, but they're gone up. So the onus is on us to aggressively treat even after stopping. Like, you can stop, but make sure that it comes up. Another my major grouse is that majority of the cath packages now do not contain lipid profile. And that is something the Vincas should very strongly recommend, because let us all look into our own packages. Most of the cath packages now do not contain lipid profile. An extended lipid profile, another question which even though it is not exactly lipids, whether we should also, when we do in high-risk patients, should we consider HSCRP also? Because we know that HSCRP also, Paul Ridker is very strong about that. So, and the inflammatory part. So again, Dr. Ubendra Kaul's data on young ACS. Young ACS is important because the ladies with pregnancy and almost they will be young. And we found that the plaque erosion was quite high and everybody had OCT, and they had the fibrous component was much more than lipid component percentage wise in Indian young MIs, all STEMIs, okay, all STEMIs. So that is also something to think about. So we have to think at the lipid paradigm and beyond that.
Pavni, can we go to the next question? Next. So this reproductive age we already covered. Next. And undergoing, as we covered for the other important thing we are nowadays seeing is a lot of women with infertility, and quite a number of them have PCOS. So how do you manage the lipids or how do you screen these women who are undergoing fertility treatment, and how should we do it? I think I'll ask Dr. Mohanjit and Dr. Selvarani. Dr. Mohanjit is an endocrinologist and they'll be dealing with a lot of infertility patients. How do we manage these patients? And Dr. Selvarani, how do you manage them?
Yes, actually I am visiting one of the infertility center in Madurai, Sudha Infertility Center, where between 40 and 45 people are coming, and I am screening them for dyslipidemia. And I recommend them statin therapy. I am yet to start a non-statin therapy for them, except for morbid obesity. But to my surprise, South Indian morbid obesity people, they do have values of lipid within normal limits. So lifestyle modification, weight reduction, and I prefer to go for rosuvastatin and orlistat after ruling out all the hypothyroid and other things.
But they are considering pregnancy, so you're okay with starting statin in these patients who are coming for infertility treatment and planning a pregnancy?
So this is a difficult situation. The success rate of trying for the patient is only 50% as far as ICSI and other things are concerned. So once they become urine gravindex positive, then the treatment is changed. That is what done here.
It's a very difficult situation as predicted. Maybe as Sarita said, giving one inclisiran shot before they become pregnant to us is looking very, very attractive, though we don't have data on that. So,
Madam, that may not be. Can I add a point? I think
yes, sir.
Giving inclisiran prior to the lady becoming pregnant, I don't think it is a good idea. Because you are giving a small interfering RNA molecule to someone which will act for a very, very long time. And we are not too sure what all things this siRNA will do. And in a pregnant woman, I think we don't have any data of inclisiran. So I feel inclisiran is one drug which you should avoid in a patient who is going to become pregnant.
What about the other drugs, Ezetimibe or
Ezetimibe also, I do not think we are having good data. Now, regarding your question of fertility management, one problem is most of these people are in their late 30s and early 40s. And a good percentage of them have hormonal issues, metabolic syndrome, polycystic ovary syndrome. Many are diabetic, hypertensive. So they are a very, very high risk group. So I think there should be a multifactorial approach. You should concentrate on lifestyle management, good hypertension control, good diabetic control with optimum drugs. Again, avoiding ACE inhibitor, ARB, and choosing the appropriate drug for management of diabetes. And regarding lipid management, I think we have to be very, very careful because we are not supposed to ordinarily prescribe statin in the, someone is going to become pregnant in the next 2 to 3 months. Unless they belong to the category of very high risk or heterozygous FH or post-MI patient or something like that. Anyway, I will consider inclisiran in such a patient.
It's no longer in the blood circulation, inclisiran.
That is true, madam, but we don't know. We are not too sure. We are not too sure what will be the long-term effect of a drug which has never been studied in pregnant people. And there's no FDA approval for that, for use of that in pregnant people. At least you take
not
statin.
in pregnant.
See,
Dr. George, what about prior to pregnancy?
That is true, but we don't know. We don't know anything about that, We don't know anything about that. That is something we are totally unaware.
When we talk about cholesterol, lipid management is very important for a woman who's also going for IVF or for conception or anything, because the higher cholesterol and the LDL, that is actually known to be linked to a lower chance of live birth following IVF. Also, they've said that there's elevated cholesterol can increase the oxidative stress in the ovaries, and it can also impair the follicular development. So control of cholesterol is also linked to having good outcomes from pregnancy and from IVF. So we have to somehow hit the cholesterol, and that has to be before the lady gets pregnant. So either using statins before she gets pregnant or using a shot of inclisiran, something has to be done for the women who are at high risk with high cholesterol levels.
So now Dr. Gopalakrishna has shared one slide. He showed that women with dyslipidemia have poor oocyte quality, and still we need data on this combination of infertility, dyslipidemia, and it's a scourge of this century because the pregnancies are becoming later and later, and then we have more disease like PCOS, and infertility is a big issue, and we have dyslipidemia. So maybe we should up this.
Ma'am, shall I ask you something? See, physiologically in pregnancy, the lipids all go up. So having a high lipids during pregnancy may not be that dangerous, except in very, very high risk patients like familial. We are not talking about that kind of patients. I'm ordinarily about infertility. When that context, I'm asking why should we aggressively manage lipids in the pregnancy period or just before contemplating on pregnancy? I don't think so, because physiologically there is an increase in all the lipid fractions, especially triglycerides, LDL. Definitely they go up during pregnancy. So there is a physiological need for going up in every normal pregnancy. So why should we suppress it in infertility patients?
No, Dr. Shiba, we are talking not about lipid profile recommendation is preconceptual. Before pregnancy, we should need to have a lipid profile, not a lipid profile during pregnancy to take decisions. So all of us are talking about hyperlipidemia before, not
Yes,
during
ma'am.
pregnancy.
That's what I'm saying.
Madam, I
Only
think
lifestyle modification is required. A proper diet, a nutritional therapy, a proper advice is required, and not a drug during pregnancy in such patients. That's what I'm saying. Because
No,
of
I think
physiological
if you
is
go
high.
by the data on the safety of the pharmacological drugs, pharmacological data in pregnancy, probably the only safe drug is a bile acid sequestrant,
Yes.
which no longer we use. We don't have robust data with any other drug. The only other drug which FDA also has cleared now is a statin. So if you are inclined to use a drug because the individual is at substantial risk, I think we should stick to statin. I don't think we are having any data with ezetimibe, bempedoic acid, inclisiran, or PCSK9 inhibitors in a pregnant lady or someone who is going to become pregnant. We don't have any data.
Can I add one more point?
Yes.
I agree with what Dr. Shiba and Dr. Koshi says. Koshi sir has been absolutely he's hit the nail on the head. There is use of inclisiran is speculative. There is absolutely no data. We cannot recommend it. We should not talk about it. The point about preconception lipid profile is only a marker for a problem during pregnancy. Strict lifestyle modification. If there is a secondary prevention or very high familial hypercholesterolemia, or therein if you have done a calcium score or something and shown some kind of marker very strongly suggestive of atherosclerosis, you take a shared decision and continue statins. No other drug has been proven. Only statins can be used in such scenario. I think inclisiran is a very long shot. We cannot write it without any paper on that.
See,
Next slide.
more prudent question is whether we have to stop statins in not so high risk patients prior to pregnancy. That should be that should be the question, rather than like preconception, the LDL is high, so give them statins or anything. So
I think we should. In low risk people, the statin should be stopped.
absolutely, I agree with that.
So next slide.
Now, because the risk of elevation of LDL over a period of 10 months is not substantial, nothing will happen.
So I would ask the next question. Priya, are you there? INOCA patients. Hetan and Priya, how do we treat them? Do we treat the lipid goals as aggressively as, because INOCA is for women, coronary ectasia, INOCA, women. Do we treat them as aggressively as we treat the other patients?
Yes, I would think that we should treat them as aggressively, because we know that patients do have sometimes they even develop regional wall motion abnormalities with INOCA and coronary ectasias. So lipid lowering will be definitely important in prevention of any coronary events.
Hetan?
I agree with Priya. I agree with Priya. The INOCA, coronary ectasia, and hypertensive, they are the like a future subset of HepF and a future adverse cardiac event. So our role of lipid management is as aggressive as possible.
So
we can't withdraw the treatment.
Is your LDL
Statin
goal
is the first line.
55? Is your LDL goal less than 55?
Yeah.
Okay.
Yeah, yes, obviously they are the high risk subset. So my goal would be not in hypertensive. Hypertensive, I would keep it around 70, but other two subsets, yes, it is established. And now there is I think a demarcation that primary or secondary prevention. Once the atherosclerotic plaque is established, it is a continuum process. And it is a INOCA, ectasia, they are the established CAD. So my goal is as low as possible.
Next slide, Pavni. I think we are coming to the end. So already adverse pregnancy outcomes patients. When do you screen their lipid profile, and when would you what would you do? Annie is there. Annie is left, I think. Adverse pregnancy outcome patients. When would you screen them? Heather, when would you screen the APO patients, adverse pregnancy? Shiba ma'am, you want to answer that question? When would you screen them?
Means adverse pregnancy outcome means with the gestational diabetes and
diabetes.
Yeah. So they should
hypertensive
be, they
disorders.
should not be left alone. Like we
When do you want to
in
screen them?
India. Yeah, immediately after the delivery, within the 6 weeks, I would like to have a baseline parameters, and gestational diabetes. The recommendation is every year the HbA1c should be monitored. But lipid profile, it is a continuum, and I need to monitor it immediately after the 3 months of the event. Yeah.
Next question, Pavni, go on. So the last question, do we manage, how do we manage low HDL in women? Dr. Prabhakar has been telling us that low HDL is very common in women because the cutoff is 50. Should the cutoff remain at 50 for women? And should we treat the low HDL? How do we treat the triglycerides? Dr. Prabhakar?
Yeah, thanks. HDL is only prognostic. If you're low HDL, you have a high risk. That's all. By bringing up the HDL medically with medication is not proven. That's clear. Only lifestyle modification or HDL cholesterol. No drug is really proven to show. Even if it increases HDL, it does not promote reverse cholesterol transport. Next is high triglycerides. Women actually have lesser of high triglycerides compared to men, but it's more prognostic. 50% of triglycerides can be controlled by lifestyle modification, clearly. So I think primary treatment of triglycerides is lifestyle modification. Next, if it is not more than 450, statins again. Nothing.
So we would like to share the Google survey which we did, and we request you all to, if you have not filled the survey, Prerna, can you share the questions and can you share the survey which we circulated among the WinCars? And if you want to add, Dr. Prabhakar, Dr. Koshi, if you all want to add more questions, we'll circulate.
I just wanted to ask you something because a lot of senior cardiologists are here in our group now. What is your experience of treating an ACS during pregnancy? I understand it is extremely uncommon, uncommon. ACS in pregnancy. We do encounter sometimes coronary dissection and all that. But how often have you encountered ACS in pregnancy? Even in so-called elderly female, elderly primary and all that. And how often you have done a primary angioplasty or thrombolysis in a pregnant woman?
Koshi, Judge Koshi is at Somraju.
Yes.
In my whole career of more than 50 years, I saw only one patient in 1975, an acute myocardial infarction in a pregnant lady. She was around 40s. And then those days we don't have any of these things. And I also agree with you with what you said. This reductionist approach of concentrating only on cholesterol, we should avoid. Look at the totality and wholeness in dealing with these patients. Thank you.
Thank you, sir. Thank you for your valuable inputs at this point of time. We'll quickly go through the survey so that we can conclude the session. Prerna, go through the survey, please.
Pavni, can you share the slides, please?
Yeah, sure, ma'am.
Okay, thank you.
Dr. Prabhakar, Dr. George, Dr. Somraju, request any questions to be added to this survey. Come on.
I think one point is regarding that risk stratification. There was a question as to how should we stratify for ASCVD. Is it similar to male? then we all mentioned that certain other things have to be included. I think we should define which are the things which we are going to include, like age of menarche, age of menopause, pregnancy-related hypertension, gestational diabetes, preeclamptic toxemia, polycystic ovary syndrome, or treatment for CA breast, chemotherapy, radiotherapy. I think we should enumerate them.
Okay,
And then try to understand how many risk factors are there, and probably what is the impact of each of these risk factors as an ASCVD. Because when you ultimately analyze, that is the only difference between male and female gender. Because hypertension, diabetes, and all other things are all common. The other things which are very specific for the female are these two areas. One, pregnancy related, then the hormone related menstrual cycle, then the oral contraceptive and all those areas, then metabolic syndrome, polycystic ovary syndrome, then CA breast and all that. So that area should be very well defined.
Autoimmune diseases also, sir.
Autoimmune disease also, I forgot to mention.
Yeah.
Autoimmune disease, sorry. Good to point it out.
Prerna, go through the questions very quickly.
Okay, ma'am, I'll do that. So the first question is, which of the following statement about familial hypercholesterolemia in women is true? So should we tell the answer, or we ask the panelist, ma'am?
No, I think the time is short. These are the things. We thought that you can go with the answers. And
Okay,
any controversy is there, Dr. Prabhakar or Dr. George Koshi?
Okay. So the maximum answer we got here was the number 3, that is diagnosis is often delayed in women, leading to higher burden of acute AS. I can't see this.
CVD.
Okay, no controversy on that.
Okay, fine. Next slide, Pavni.
Okay.
According to you, what is the recommended age to initiate?
We already went over it. We recommended at college going age.
Yes, ma'am. So actually, we got the most answer was 20 to 39 years. But as the experts say, I think number 1.10 to 15 years.
Oh no, 15 years.
Follow menarche. Sir, at the point when the patient, the student attends college. That's what we thought.
So,
next.
Okay. So the next is, Bhavni, please play the next slide.
Bhavni, be fast.
How does pregnancy typically affect a woman's lipid profile?
This we already discussed.
This is already discussed, increase in TG and HDL-C level. Next slide, please. Which of the following is a primary reason why lipid screening is often recommended around the time of menopause?
We know this.
And increased risk of developing gestational diabetes. Actually, the answer which we got maximum was number 2, ma'am, actually.
No.
But isn't it 3?
Third one.
Third one, okay.
I think it is a loss of cardioprotective effect of estrogen.
Yes. Next one, Pavni. 25-year-old woman with the family history of premature cardiovascular disease should be screened for dyslipidemia at what stage? So the maximum answer was at a young age, that is 2 to 8-year-old or by puberty.
No, your question is a 25-year-old woman, so you cannot check it earlier than 25 years, no?
25 years. So should be 25.
She is 25 years already. Then check it immediately at that point of time.
Or 25.
So
yes.
we write the answers. This is what we got in the Google survey, actually.
Okay. Ideally, it should have been checked earlier, but she came only now.
So 25 years is the answer.
No,
So, Pavni, we can correct the answers. We can recorrect the data.
And I think you can reframe that question as to family history of premature cardiovascular disease or heterozygous FH. At what age should be screened? And it should be at a much younger age, probably in the first decade of life.
Yes, sir.
The American Academy of Pediatrics is 2 years.
Okay.
So that is the cutoff given by American Academy of Pediatrics.
Okay, fine. Thank you so much. Next slide, Pavni. Number 6. Pavni, please play the next slide. Which of the following is true regarding lipid screening during pregnancy? So here we got the answer. A baseline lipid profile is best obtained before or after, immediately after pregnancy.
Okay.
Next one, please. The decline in estrogen level during menopause is associated with which of the following changes in women's lipid profile? So maximum answer was an increase in TG and LDL-C.
Okay.
Right.
Okay, next one. Which of the following is an accurate statement about the physiological changes in a normal healthy pregnancy? So here the maximum answers were lipid levels including total cholesterol and TG are at the peak during the third trimester of the pregnancy.
Yes.
Okay. Next.
Oh, next one, please. 35-year-old woman with no known cardiovascular risk factor other than a recently obtained gestational diabetes should have her lipid profile screened at what time? So the answer was at her 6 weeks postpartum visit.
Yeah, this was discussed and Hetan was also on that. Next.
So we can continue with the same answer. Next is, what is the primary effect of the decline in estrogen level after menopause on LPL activity? So the answers, maximum answers were, it decreases LPL activity leading to higher TG level. So any comment by the experts on that?
I think that is okay.
Next.
Oh, okay, next one, please. Early stage of menarche and an irregular menstrual cycle may be linked to an increased risk of future cardiovascular diseases through which of the following mechanism? And the answers we got was indicators of underlying hormonal imbalances that can lead to dyslipidemia and cardiovascular diseases.
Okay.
Okay, thank you. Next one, please. What is the, okay, fine. I can read the whole slide now. What is the primary reason for the contraindications of statin use during pregnancy? And the answer was statins inhibit cholesterol synthesis, which is essential for fetal development.
Okay. There's a lot of discussion on this. Next slide.
Okay. Next one, please. A woman on long-term statin therapy is considering becoming pregnant. What is the recommended management plan? I think already we
It was
have
discussed. Yeah.
So
low
discontinue.
risk, stop. That's what the people said.
I think it's 1 to 2. I think it should be 3 months, ma'am. We can remodulate the answer.
Oh, no,
also.
1 to 2
Probably
months.
3
1 to 2
months.
1 to 2 months. 1 to 2
Probably
months.
3 months.
Okay, fine. Next one, please. Which of the following statin side effect is more commonly reported in women compared to men? So here the answer was myalgia, that is muscle pain.
Myalgia. Okay.
Next
But
one, please.
Dr. Prabhakar said there's no difference between men and women. Okay. Slide.
Okay.
The studies showed that myalgia was more common in women. All the clinical trials showed that. So I think that answer is right.
I think myalgia is commoner in women even otherwise compared to men.
Okay.
Irrespective of statin.
That is
Thank you so much, sir. A woman who has recently given birth and is breastfeeding should. So here the answers which we got maximum was resume statin therapy only after she has stopped breastfeeding.
I don't think that is totally acceptable.
Except in very high risk patients like familial heterozygous hypercholesterolemia.
For them, we don't stop statins, right? This is the guideline. So breastfeeding is also, statins are secreted in breast milk. So we had to, but the guidelines is the same. So we had to follow the guidelines.
So what should the exact answer be, sir?
No, I agree with this answer because if the patient is already on statins, the question is moot. And patient is not on statins, then because statins are secreted in the breast milk, I think the answer should be the second one.
But okay, Abraham Woman, do you think the risk is the same during pregnancy?
Nobody
and
knows. It's the same as that of the inclisiran question. Nobody knows. So it is like, since there is a recommendation like that, it is excreted.
Better to do that.
Better to do that.
So
no, I think high risk people, we can tell that they should stop breastfeeding earlier and switch over to statin.
Absolutely.
Okay, that's right.
Okay, thank you so much. So the next question is, what is the main reason for an increased risk of myopathy and myalgia in women on statin therapy? So here the answer we got was differences in drug metabolism and pharmacokinetics. So I hope the panels agree with that.
Yes, yes.
Okay. So the next one slide, Pavni. For a woman with PCO and elevated LDL-C, statin therapy may be considered too. So the answer obtained was improve insulin sensitivity and reduce CV risk.
That is okay.
Okay, fine. Which of the following is the most significant reason for the historical and ongoing underrepresentation of women, particularly of childbearing potential in cardiovascular and dyslipidemia clinical trial? So here the answer which we obtained during the survey from maximum participant was concerns about potential teratogenic effects of new drugs on a fetus.
I think that is true.
Okay. Next one, please. Which of the following classes of lipid-lowering medication is generally?
Yeah, I think.
Safest. That is true, though we are not using it.
Yeah. Next slide, Pavni. I'll read it. So, Mohanjit, you're there? Sir,
discussed in the slide.
We are trying to increase the female enrollment, and now there is a clear recommendation that there should be female investigators and do more data analysis so that we get more data.
We have on Pavni, please.
Yeah. So the clear outcomes trial had already recommended.
See the screen, Pavni.
Yeah. I think Mohanjit, that's enough, and we can go over to the thanks session, which we thank all who have attended this. Mohanjit? I think she went offline. Thank you, sirs. It has been a pleasure interacting with all of you. I thank all the WinCar members and especially the men who have been part of this incredible meeting. I have thanked Dr. Somaraju, Dr. Prabhakar, Dr. George Koshi, Dr. Abraham, who have been so instrumental in taking the discussion forward in this session. And we hope to have more interactive sessions with all of you so that we can develop our own guidelines. And we would like to see on behalf of WinCars that we are ready to take part in any of the trials which you plan, and so that we can generate more of data in women, which would be very, very helpful in reducing outcomes in women. Thank you, one and all.
Ma'am, Sujata ma'am, real thanks is to you actually. Thank you so much.
Thank you. Thank you.
Thank you very much. Yeah.
Thank you. Good night.
Thank you, everybody.
Thank you.